Thank you. I'm delighted to be here. I presented my job market paper at the first annual Midwest Health Economics Conference. So this is a reminder of how much I have aged. It's been 11 years. This is joint work with Tim Layton and Daniel Prinz. I think they're actually in the room, hopefully because I've had computer problems. And so there's a chance this will all fall apart and hopefully they can take over. And that would be on brand for 2020. We have to be prepared for disaster. So let me start this way. This paper we view as kind of at the intersection of two discussions, one within health economics and one outside of health economics. Within health economics, there's been an enormous discussion over the decades about cost sharing. And by and large, economists are in favor of cost sharing. We can debate the details, but in general, health economists believe that some people should face some cost of their healthcare. And as a result of that academic agreement, there's been an increase in cost sharing in the real world. So you can see that in this graph from Bloomberg, the share of Americans with a high deductible healthcare plan is around 50% these days. And these things used to be pretty rare. So cost sharing is becoming more common, and it more or less has the support of health economists. At the same time, so that's like one piece of the thread. At the same time, there's a discussion outside of health economics in the field of household finance. And there's been a particular finding we're interested in that's been demonstrated over and over again. The timing of consumption in general depends on the timing of income. And I'll give you one example of this, but there are many others. Olafsson and Pagel have a paper that was published in a top finance journal a couple of years ago, where they show that low-income households spend 70% more on days when they get their paycheck than on the average day. And this is a finding that exists in many other studies. I'm just mentioning a few of them here. What seems to happen is that people wait until their paycheck arrives before they go out and buy stuff. What we want to ask is how to think about that fact in the context of health insurance. Because in health insurance, what we hope happens is that people buy healthcare when they need it, not when their income arrives. And let's make this concrete. Think about something like Lipitor, which is a drug that you're supposed to consume every single day. And so your doctor, no one ever says this, but the doctor never tells you, okay, here's consumption. You need to consume this drug and wait until you get your paycheck. They tell you, you need to consume this thing every day. You need to take your pill every day. And yet, if you ask Americans in the past 12 months, have you not taken a medication as prescribed to reduce costs? 8.4% of insured people, and these are people with a medication, will say that yes, in the past 12 months, I've deviated from a prescription to reduce costs. So what we want to ask here is whether this income timing issue, this thing that we're going to call liquidity sensitivity, that consumption is sensitive to liquidity, whether that applies to healthcare. Because if it applies to healthcare, then that might have policy implications since healthcare timing matters. Our research questions are the following. First of all, is the healthcare consumption of low-income consumers liquidity sensitive? Meaning, we know from the literature in household finance that people delay buying a big screen television until their tax rebate arrives. But I don't care about big screen televisions, I care about healthcare. Is the same finding true of ordinary healthcare consumption? And then secondly, the question is, how does that liquidity sensitivity relate to price sensitivity? So health economists have shown over years that people are definitely price sensitive. If you raise the price of healthcare, people consume less healthcare. The question we want to address is, how does that relate to liquidity sensitivity? Meaning, are the people who are most price sensitive, are they also liquidity sensitive or are they less liquidity sensitive? It's kind of a vague question, but we'll be concrete about what that means. And the bottom line question we have here is, how should health insurance be structured for low-income consumers? You know, when it comes to me, I face $20 copayments, and maybe those copayments induce me to consume healthcare more judiciously. But for someone who's occasionally liquidity sensitive, who oftentimes doesn't have cash, who's very much waiting for a paycheck, the effect of copayments might be very differently. And so we might think about health insurance very differently for that person than for me. And the way we're going to study this is by focusing on Social Security checks. Social Security checks, as many of you know, are distributed in a particular way that allows us to compare someone who just got his check to someone who's 2 weeks away from her check. And we're going to study how Medicare-covered drug consumption under the Medicare Part D program changes as Social Security checks go out. So let me first preview the results because I'm worried about this laptop and you know, if 2020 has taught us anything, it's that bad things are always about to happen. Let me just give you the results in case you know, things go bad here. So what we're going to show you is that prescription fills increase by 6 to 14% when Social Security checks are distributed. So millions of Americans, there's 64 million Americans on Social Security, they get their checks, and overall prescription fills go up. They go up even for expensive drugs, even for important drugs that you really need to consume every day. When we take those people, we have panel data here, when we take those people and we eliminate their copayments, we see that they stop doing this behavior of delaying their fills until payday. So this is a behavior that's intimately tied to copayments. When we eliminate copayments, it goes away. And in particular, those who tend to fill scripts on Social Security paydays exhibit a price elasticity of demand that's twice as large as other recipients' price elasticity of demand. The guys, our guys, quote unquote, who are driving this behavior, who are doing this, who are delaying scripts until payday, those people are the most price sensitive. Right? And if we could somehow get rid of them or shift them onto Medicaid, the overall price elasticity of demand would go down. All right, there are two mechanisms that might be at play here. We think both are relevant for different people, and we can't disentangle these. One explanation is straightforward liquidity constraints, that these people just don't have cash, and so they have to wait till their Social Security check arrives until they can fill their scripts. That's probably the case for some people out there. And in fact, a lot of the results we're going to show you are consistent with that explanation. At the same time, we're also going to show you that this behavior exists for people who face $2 copayments for generic drugs and $5 copayments for branded drugs. And even though we're focused on very low income people, it seems surprising that those people are literally liquidity constrained. And so an alternative explanation is some sort of mental accounting or behavioral friction, or what we call in the paper a liquidity related friction. Either of those two stories are potentially driving this, and we think both might be relevant. We take the second one and we're going to propose a simple framework to quantify the share of moral hazard-driven deadweight loss that can be accounted for by liquidity sensitivity. The way we think about this big picture is that normally we see price goes up, quantity goes down, and we call that moral hazard. But part of that is not moral hazard, it's liquidity sensitivity. And so that's where we think this is headed. And we hope that other people kind of build on these results and explore the implications of our results. So this talk in my 35 minutes is going to proceed very quickly. I'm going to give you background as quickly as I can. And then we have two empirical exercises. The first exercise is a straightforward program evaluation. We're going to try to understand the effect of Social Security checks on prescription fills. The second piece is we're going to look at panel data. We're going to find people who see their copayments go down to zero or whose copayments was zero and then they go up to some positive number. And we're going to study what happens to their behavior when it comes to this liquidity sensitivity. And then finally, time permitting, we want to present a very simple framework for how to think about the policy implications. So let's go through some background. This is what we're living off of. This is a flyer that was sent out to 64 million Americans in 2019. A similar flyer went out in 2020. Every year, the SSA sends out a flyer that looks like this. It's one 8.5 by 11 sheet of paper, and it tells people when their checks are going to arrive. I'm going to zoom in here. So this is April of 2019. There's a couple things we're going to ignore. SSI recipients, we try to cut out. People on the old schedule for Social Security, we try to cut those people out. And so we're left with the schedule on the left here. If your birthday is on the 1st through the 10th of the month, then you're going to get your Social Security checks on the second Wednesday of each month. If your birthday is on the 11th through the 20th of each month, you're going to get your you're going to get your Social Security check on the third Wednesday. And if your birthday is on the 21st through the 31st, you have to wait till the fourth Wednesday. And so this is our quasi-experimental variation. We're going to compare people who are getting their check on the second Wednesday to people who are getting their check on the fourth Wednesday and see how the check affects behavior. In addition, the way that the calendar works, 2/3 of these checks arrive after a 28-day wait. So there are 28 days between the second Wednesday of one month and the second Wednesday of the next month, 28 days between the third Wednesday and the third Wednesday, so on and so forth. And then a third of checks, give or take, come after a 35-day wait. And this is just how the Gregorian calendar works. Because months are irregular, they don't all have 28 days. It's not the metric calendar. We end up with a third of checks arriving after a 35-day wait, and that's something we can exploit because it's balanced across the calendar, and we can compare 35-day checks to 28-day checks. In addition, we have what we call 3 copay groups, and this is our summary of the Medicare Part D program. There's the no copay group. That's what we're calling them. These are people who face no copayments when they go to the pharmacy to pick up their scripts because they're Medicaid enrolled. So they're Medicare, Medicaid duals. And they still get Social Security checks. That's very important here. They're still on Social Security and they get their checks on the same schedule as everyone else. But when they go to the pharmacy, it's all free. They pick up Lipitor, they pay nothing. They pick up an anti-seizure medication, they pay nothing. Second, we have the subsidized copay group. This is our phrase. These are people who are low income, and so they're on the LIS program, the low income subsidy program. They pay no premiums for Medicare Part D, but they have to pay small copayments. It's $2 for every generic, give or take, and $5 for every branded drug, give or take. And then finally, the biggest group is everyone else. We're calling them the full copay group. Those people pay premiums and they pay the full copayment. The copay varies. It depends on where they are relative to the donut hole, but it's more typically than $2 or $5. So the biggest group by far is the full copay group. We're using a 20% sample. So we have 3.7 million people who are in that full copay group. That's the biggest group we have. Then we've got over 500,000 people in the no copay group paying no copays, and then a tiny sample of 140,000 people who are in that middle group. The middle group, they pay tiny copayments, but they're very low income. And so, it's not obvious a priori where we might expect effects. All right, I'm going to skip some histograms. Here's the summary of our variation here. We have these different check dates. We can compare someone who just got his check to someone else who hasn't gotten her check until, not for 2 weeks. We have these different copay groups. Some people face copayments and others don't. So that's a control group. We have these 28-day checks versus 35-day checks. And so we can compare those two things. You might expect 35-day checks to have a bigger effect. And then we also have different beneficiaries, different drugs, and we can split this up in all sorts of different ways. All right, so let's do the overall analysis. Here's what we're going to do. A first empirical approach before we get into regressions is we're just going to take the raw data and do some differencing and averaging. So this is going to be the simplest possible cut of the data. We take every event day. By event day, we mean days until your check. And we calculate the difference in scripts filled between beneficiaries who are about to receive their check and beneficiaries who are 2 weeks away. And we can perform that calculation not just for the copay groups, but also for the no copay group and use them as a control group. So this is the graph that we're going to use, the axes. Event time is on the horizontal axis, days until the checks are distributed. On day 0, checks are distributed. And the y-axis this is not a regression, so this is just us differencing things across groups. So it's the logarithm of total scripts for the group that's closest to receiving their check minus a different group, a different payday group, meaning a group that's going to receive their check in 2 weeks. Here are the means for the no copay group. Now, I've said this before, but importantly, these people still get their Social Security checks on day 0, but they don't face copayments when they go to the pharmacy. And so we see no effect of the Social Security checks on them, right? There's just nothing here. But then here's the subsidized copay group. For these guys, we see a big effect. When checks go out, scripts go up by about 10% for this group. We observe an effect on day -1, which is surprising to us. And we think the day -1 effect is actually not an anticipatory effect, but what's going on there rather is that some banks deposit this check a day early. And we reached out to experts at the Council of the CFPB, the Consumer Financial Protection Bureau, and they talked us through how these transfers are made. And the day -1 effect is that a minority of banks will just transfer this a day early. All right, but then there's a 10% effect on day 0, and then it dissipates and goes back to baseline. All right, here's a regression framework to have standard errors. So we're going to have a fixed effect for every birthday group, 1 through 31, a fixed effect for every calendar date, and then we're going to estimate the effective event time before and after these checks are sent out. And here are the event study estimates like before. For the no copay group, we don't really see anything. And then we've got the subsidized copay group, more than a 10% increase on day 0, and then it returns to baseline. And here's a summary of that event study graph, but let me be clear here, we're going to take just the day 0 estimate, just this thing over here, and plot it for every different group. So for the no copay group, people who face no copayments when they go to the pharmacy, we don't really see anything. Then for the subsidized copayment group, these are the lowest income people. They face $2 or $5 copayments when they go to the pharmacy. We see big effects above 10%. And it's noisy here because we don't have that many of these people, but there's a bigger effect for checks that come after 35 days since the last check relative to checks that came after 28 days since the last check. And then finally, we have the full copay group. The confidence intervals are much narrower because this is just the biggest group by far. This is everyone else. And they're much higher income on average. So we've got a smaller effect. It's a 6% increase in scripts when checks go out. And it's clearly a bigger effect after a 35-day wait than after a 28-day wait. All right. Now here's a stratification where we stratify by all these different characteristics. And given I have limited time, I'm not going to dwell on these, but we find bigger effects for branded drugs, bigger effects for more expensive drugs, meaning drugs that are at the above median out-of-pocket cost. We find statistically significant increases both for refills and also for first scripts. And we think it's important that we estimate a statistically significant increase in first scripts because refills are confusing to think about since people still might have pills left over from the last fill. But when you're delaying a first script, that means you're going without drugs. And so just that stratification we think is important. We find effects for what we call chronic drugs or acute drugs. Either way, it doesn't matter. And then we interviewed physicians. My 2 co-authors here, Daniel Prinz and Tim Layton, are at Harvard Medical School, so they have the luxury of being able to ask physicians all sorts of questions. And they asked their colleagues, what are some drugs that are really important that lead to short-term problems if you don't take them? And this is the list that they got. So Plavix, I think you have some sort of cardiac problem if you don't take it. Warfarin is a blood thinner. You're going to get a blood clot if you don't take it. HIV is a problem, HIV drugs. Antipsychotics, if you don't take that, you'll have a psychotic episode. And if you don't take your anti-seizure medications, you'll have a seizure, so on and so forth. We're seeing effects for almost all of these. For HIV, it's very noisy. In this population, we don't have that many HIV positive people. Antipsychotics are also somewhat noisy, but for everything else, we see an effect that we can distinguish from 0. So there seems to be an increase in all of these scripts when checks are going out. In addition, we see effects across all beneficiaries, all groups. It doesn't matter that much whether we stratify on race. If we look at chronic conditions versus people without chronic conditions, we still find effects here. And I want to show you the stratification by income. So unfortunately, we don't have actual annual income. What we have is every beneficiary's zip code of residence. So we merge in the median household income in your zip code of residence, which is obviously a noisy measure of actual income. But we find a very clear monotonic pattern. In the lowest income zip codes, we see the biggest effects of Social Security checks. Highest income zip codes, it gets much smaller. So this is a pattern that's driven by low income areas. All right, it's disproportionately in low income areas. All right, so to summarize here, we're finding a 6 to 14% increase in scripts being filled. The effect is large, and it's larger in certain populations than other, but it's statistically significant in most of the stratifications I just showed you. The prescription filling is highly sensitive to liquidity, even with very generous insurance. These are in that middle group. These people only pay $2 for generic drugs, and yet we still see an effect here. So the mechanism is hard to pin down. What we can rule out is what we call the bus fare effect. When we first started working on this, we wondered whether an issue might be bus fares, meaning that to get to the pharmacy, you have to pay for the bus. And so maybe you're going to wait till your Social Security check arrives, not because of co-payments, but because you need to pay for that bus ride. And we can reject that story because we don't find an effect for the no copay group. So we don't find an effect for people who don't face co-payments. And so this seems to be a pattern that's intimately tied to co-payments, not to anything else, not to transportation. It's not about returns to scale in shopping or something like that. But there are other two mechanisms that are harder to disentangle. It could be real liquidity constraints that you have no cash, or it could be mental accounting. And it's hard to distinguish between those two stories. Either way, whether it's liquidity constraints or mental accounting, we're going to call that a liquidity-related friction. Okay? And now let's go into a second set of empirical exercises. That's the overall effect. What we want to do next is look at people and track them as their co-payments change. So we're going to analyze the effect of insurance generosity in 3 steps. First, we're going to assess price sensitivity. We've got people who are seeing their co-payments drop because they go onto the LIS program, and we're going to measure their price elasticity of demand by looking at what happens to their drug purchases. This is not a novel contribution to the literature because there are other studies out there that have estimated the price elasticity of demand. There's the Rand Health Insurance Experiment, but also for Medicare Part D, there's work by Amy Finkelstein and Liran Einov and co-authors Paul Schrimpf, Polyakova, and so on. But this is a first step. So we're going to estimate price sensitivity. Second, we're going to estimate liquidity sensitivity, and this is novel. To our knowledge, no one has done this. We're going to see what happens to this behavior of spikes on Social Security paydays when insurance generosity changes, when people suddenly face no co-payments. And third, we're going to look at the interaction of those two things. We're going to see whether the people who are liquidity sensitive are more or less price sensitive. So this is going to be in 3 steps, and I'm going to signpost this because I think it's a bit of a complex set of analyses we have to do here. But the first step should be near and dear to every health economist's heart. We're just going to try to understand how people respond to prices. All right. So here's the variation we're studying. We've got people in this graph who are switching from a copay group to the no copay group. So all of a sudden, their copayments go down to 0. And we're going to study, this is price, this is their average out-of-pocket costs, what happens to quantity? Well, here's the same graph, but for average monthly scripts. And what you see is, first of all, there's a positive trend. As people get older, they're more and more likely to have prescriptions and to accumulate new prescriptions. But there's clearly a move from the trend, a deviation from trend when copayments go down to 0. So this is shifting from copay to no copay. We can also look at the reverse. And this is going to be noisier because we have fewer reverse switches. We have fewer people going from the LIS program where they face no copay payments from Medicaid enrollment to shifting out of that. But we can still study the people who do switch out. So we see a sudden increase in average out-of-pocket payments, and we see, sure enough, a sudden decrease in utilization. Price goes up, quantity goes down. Right? Let's put those are just means. Let's look at some regressions. So we're going to have log counts of scripts as our outcome of interest. And also we can look at out-of-pocket payments. We are going to have an individual specific fixed effect here and a calendar date specific fixed effect. And then this looks complicated, but it's basically just a dummy for being post, for being after your transition. All right, so here's the switch from being on a copay group to being on a no copay group. We find an 8% increase in total scripts, and that leads us to a price elasticity of demand of minus 0.06. And minus 0.06 is roughly similar to what people have found in the literature. In particular, I think Einov, Finkelstein, and Schrimpf in AJ policy, they find an estimate that's similar to that. But we can also go the other direction. We look at people who face no copayments and who transition to being on a copay group. It's the opposite. So quantity goes down, and the price elasticity of demand we estimate is similar to what we have before. It's closer to minus 0.05, a little bit smaller, but these are two different populations. These are not identical groups. We're seeing roughly similar elasticities, whether people are switching in one direction or the other. And these elasticities are consistent with the literature. So this is a first step in the analysis. That's not novel. Other people have done this, but we need it to go forward. The second step is to study liquidity sensitivity. What happens when these Social Security checks go out in this context? So how do we measure payday filling? We want to assess whether more generous insurance affects liquidity sensitivity, and we need to measure liquidity sensitivity for every person and every month, before and after they transition across copay groups. So we do that in the following way. Number one, we divide people up into the cohort based on when they switch to the no copay group. So we're only focusing here on people who are facing copayments and then they face no copayment. And we put people in little bins, little cohorts based on the calendar month when they switch. And then number two, for each quarter relative to that transition, we're estimating the share of their Wednesday drug fills that occurred on payday. And this is a novel measure that we've created to get a handle on this. So for every person, we can calculate the share of your Wednesday drug fills that occur on payday. Payday is always a Wednesday. So there are 4 or 5 Wednesdays in a month. One of those Wednesdays is your payday. The share of your Wednesday fills that occur on your payday, that's the measure we have of payday filling. We focus only on Wednesdays here because they're a huge day of week fixed effects in payday in prescription fills. People tend not to go to the pharmacy on weekends, so we can't just look at all days. We're only focused on Wednesdays. But this one measure, the share of your Wednesday fills that occur on payday, that's a noisy proxy for whether you are a payday filler or not. And this is that proxy over time as people shift from facing copayments to facing no copayments. The vertical axis here is the share of Wednesday fills on payday, our proxy. It's going up over time, and then people are switching in this group to not facing copayments, and all of a sudden it drops down to roughly the level you would expect if people were ignoring their Social Security checks. The average number, there are 12 paydays a year, and there are 52 or 53 Wednesdays a year. So 12 divided by 52 or 53 is something around here. So it seems that when we take people and we eliminate their copayments, they stop filling on payday. All right? That's the second step. The third step is the interaction. We want to understand how price sensitivity relates to liquidity sensitivity. And here's what we mean by that. We want to assess how the demand response to more generous coverage differs for the liquidity sensitive versus other beneficiaries. When we see spikes on payday, it's not the case that everyone is filling scripts on payday, right? That's just not the case. It's roughly 10 or 20% of the sample that tends to be filling their scripts on payday, waiting until their Social Security checks arrive before they fill scripts. So are those people, our guys, quote unquote, are they more or less price sensitive? For each beneficiary, we compute the portion of their Wednesday fills that occur on payday when they're on the full copay group. And then we estimate a price, we calculate deciles of that measure. So we're dividing up people into deciles of that proxy for being a payday filler. And then we estimate a price elasticity of demand for those deciles. And this is going to boil down to one figure. This is my favorite figure in the whole paper, so I'm going to dwell on this. The y-axis here is an estimated price elasticity of demand, and we're going to start with just all beneficiaries in a particular sample of people who are on the full copay group and transitioning to the no copay group. So these are people who are minding their own business, and all of a sudden their copayments go to zero. And we use that to estimate the price elasticity of demand. Overall, we get a price elasticity of demand of minus 0.04 for this sample. And that's a sensible number. It's similar to what we've estimated in those other tables, and it's what other people have estimated in the literature. And then what we do is we do that same analysis, but we stratify the sample by deciles of payday filling. For every person, we calculate the share of their Wednesday fills that are occurring on the Wednesday when they get their Social Security check. And then we're estimating a price elasticity of demand for each decile. And the paper is getting long. It's, in the appendix, we show that it's only the top 2 deciles or so who are really payday fillers. For everyone else, they're just not driving this pattern. And so here are the price elasticities of demand by decile. For the bottom 8 deciles, we don't really see much of a difference between the overall price elasticity of demand and their elasticity of demand. But then when we look at our payday fillers, the people who are disproportionately filling scripts on payday, they're exhibiting the highest price elasticity of demand. So the people who are driving liquidity sensitivity, the liquidity sensitive consumers, they're the most price elastic. And we think that's an important point that that we need to dwell on when it comes to implications. So what happens when copayments disappear? Let me summarize. When copayments disappear, people consume more drugs. That's not novel. But what is novel is that people stop waiting for their Social Security paydays to fill prescriptions when those copayments disappear. And in addition, those who were previously most liquidity sensitive are the ones who are increasing their consumption the most, are the ones who are most responsive to price. So let's talk about, in my last 3 minutes here, the implications of that. What does that mean? Well, the typical discussion about moral hazard basically says, look, we've got risk protection and we've got moral hazard. We've got to weigh these two forces. And so copayments need to balance risk protection versus moral hazard. But our work suggests that there's a third factor here. And this is similar to something Justin has done with Keith Erickson. And they explored this theoretically. There's another benefit of generous insurance, which is that when you're on generous insurance, you're able to consume healthcare when you need it, not when you're liquid. And that's a benefit of insurance that most people don't really need, but a small share of the population who is liquidity sensitive, whose healthcare consumption and whose overall consumption is liquidity sensitive, they care about that. In addition, if CMS could somehow tag the liquidity sensitive in a way that we're incentive compatible, then the overall price elasticity of demand would be lower, would be 13% lower. We think that's important. And in my last couple of minutes, I'm just going to mention a framework that we flesh out in the paper, and I'm running out of time here. It's based on the work of Josh Schwartzstein and Kate Baker and Sendell Mullin-Nathan. Here's the conventional view. The conventional view is that you've got a downward sloping demand curve for healthcare. If you're uninsured, then you face the marginal cost of healthcare and you're actually going to consume the efficient amount of healthcare. If you're insured and you face high copayments, there's deadweight loss because of overconsumption. And if you face even lower copayments, then there's even more deadweight loss. What we propose is a different framework where we say, look, there are actually 2 demand curves. There's the demand curve we estimate, there's the demand curve we see in the data, and then there's the frictionless demand curve. The frictionless demand curve is the demand curve we would observe if people didn't have this liquidity-related friction, if they weren't liquidity sensitive, if they weren't partaking in mental accounting. And then we can do the same exercise, but being uninsured actually leads to underconsumption because of the liquidity sensitive people. So when you move people onto high copayments, there is deadweight loss, but the deadweight loss is actually smaller than the deadweight loss you would calculate under the conventional model. And if you move people to low copayments, the change in deadweight loss is actually much smaller than the conventional estimate or the conventional model because of the liquidity-related benefits, because the demand curve you need to use for policy is not the empirical realized demand curve, but this other demand curve. And then what we do in the paper is try to estimate those demand curves because we observe people who are on the no copay group and on the copay group. So we actually have 2 price quantity pairs. And so we can estimate these 2 demand curves and actually calculate estimates of deadweight loss. So we calculate estimates of deadweight loss for the entire market. And when we account for liquidity, the estimates of deadweight loss are much smaller. When we focus only on the liquidity-sensitive consumers, we get a huge deadweight loss estimate under the conventional model because these people are so price sensitive. But when we switch to this model that allows for behavioral bias, then the estimates of deadweight loss are much smaller for the liquidity-sensitive consumers. Okay, so in my last 8 seconds here, let me just conclude 3 empirical findings. Number 1, prescription fills increase by 6 to 14% when Social Security checks are distributed. Number 2, copayments are reduced to 0, and all of a sudden we see people stop behaving that way. We see people stop filling scripts on Social Security paydays. And the kinds of people who are filling scripts on Social Security payday exhibit a price elasticity of demand that's twice as large as other recipients' price elasticity of demand. Now, these 3 results are based on relatively weak assumptions. It's just the standard difference in difference assumptions that we think are met in this context. Then we have more stronger assumptions we have to make in order to draw conclusions. And so the 4th finding here requires stronger assumptions, but we would argue that liquidity sensitivity suggests that optimal copayments should be lower than the optimal copayments implied by the conventional model. And we think big picture, when we talk about low-income people, our standard go-to model for health insurance needs to change because of this kind of behavior, because of liquidity sensitivity. And so I'm going to leave it at that. Thank you, everyone. And I look forward to hearing Justin's comments.
All right, let's see. You guys seeing the screen all right here? Excellent. So very glad to get a chance to discuss this paper. Gave me the excuse to really read it in depth, which I enjoyed a lot. And in fact, I think this paper is really something of a home run. I think it's going to be super impactful. And the interesting thing, and this came up a bit in some of the discussions and what Tal said, there's a sense which maybe some of this isn't entirely new. People have worried a bit that, you know, an inability to make payments is going to cause a lot of hardships for access to health care for low-income people. It's, you know, part of the reason that we see a lot of push towards low cost sharing in a bunch of programs. Medicaid, ACA has cost sharing reductions. But I think, you know, similar to some of what we've seen in recent years with having really good estimates of the effect of cost sharing on demand, the price sensitivity, having these really great estimates of this liquidity sensitivity in this very clean design using the Social Security payments, I think is just going to be very impactful evidence that this is a big deal that's going to potentially move a lot of people in policy discussions, because it's something I think everybody can really understand. And I won't spend a lot of time summarizing here because I think Tal did a really clear job doing this. I'll highlight a couple of things. I think it is important to notice that they find a significant effect even for drugs with potential for short-term complications. They find significant effects for first-time fills and refills, and Tal mentioned this point that the refills, it's a little harder to interpret because people may still have some drugs around, but if you're delaying a first-time fill, it's more likely to mean that that's a real change in consumption. And then there's this interesting fact, you know, about liquidity sensitivity being correlated with price sensitivity, which I think makes a lot of intuitive sense, but again, it's important to have the estimate. So I thought I'd give a couple of comments here, largely directed towards the idea of trying to think a little bit more of just how far can we push and understand the implications of what we're seeing here. So here's the key graph in many ways for the main result that Tal sort of showed as his first graph. And, you know, the things we take away here are there's this big spike in fills at the receipt of the check date for people who have copays. And there's no spike for people who don't have copays. And I think that really helps lock down that this isn't just something about how people organize their lives around Social Security pay dates. It's not that they happen to go to the grocery store and also happen to fill their prescriptions on these days, because then we would also see this in the no copay group. One small question I would have is it possible to think about actually benchmarking how large these effects are for prescriptions relative to the amount of liquidity sensitivity we see in other products under this kind of $10 sort of range? So could you benchmark this relative to like a grocery store thing so we could understand whether people are more liquidity sensitive or less liquidity sensitive when it comes to prescriptions? But I think, you know, the big questions I have are really questions about related to this question of how much is this really affecting consumption of the drugs versus the timing of the purchasing of the drugs. And one of the things I think we'd really like to know is where are these fills coming from, this spike? And in some sense, we'd like to know where the missing mass is. Are most of prescriptions that people are delaying until they get their paycheck a couple of days delayed, or are lots of them, you know, more than a week or two? And I don't think this graph can really tell us that. It's hard to sort of interpret it from here. So I was trying to think a little bit about how might you try to go about identifying the missing mass. And I think the idea is that you need to identify a counterfactual of how the fills would be done in the absence of the liquidity sensitivity effect. Now, you could assume constant filling, constant filling, but that's likely not right because there are these strong day of the week effects. And so what I was wondering about is whether you could maybe use the relative amounts of filling across the month for the no copay group as the pattern you would expect if there weren't liquidity effects. So we'd expect some spikes on Fridays and Sundays and whatever. And then the amount of filling will be different between the no copay group and the copay group due to the price sensitivity effect. But if you applied the pattern for the no copay group to the group with the copay, perhaps that would give you a reasonable counterfactual for where we should have seen their total fills showing up if you could just strip out the liquidity effect, but not strip out their price sensitivity effect. Doing this, you may have to actually focus primarily on the first fills, and I actually think there would be some benefits overall in the paper to focusing a little bit more attention on the first fills because the refills have this issue a little bit with the hangover from the prior months and the fact that if you have these payday spikes, they may show up there more. Okay, so let me quick wrap up. The other things I think we'd like to know, and obviously this is probably more for future work, is whether there are some health effects. So for instance, if you looked for things like ER visits or hospitalizations for uncontrolled conditions, would you see some sort of spike going on in those few days before checks come out? Standard errors are going to be big for rare events, but at least kind of knowing whether you see something would be great. And then the last very substantive but totally quibbly thing I'll make here is in the last part of the paper, which I think is really nice, and they do a nice job of laying out the assumptions you have to do for it. The one quibble I'd have, and this shows up, this isn't unique to their paper, is I'm not quite sure in this context of prescription drugs why we assume the marginal cost is above the copay rates. I think when we're really thinking about things like dead weight loss, we're thinking about the social marginal cost. And, in that case, I think we should be thinking about the chemicals and the cheap plastic bottles that are going to be high average costs, the development of drugs. But when we're talking about whether or not these people use their drugs, starting with a framework where we're assuming that people are sort of creating a dead weight loss by more consumption because their price is below marginal cost just doesn't strike me as obviously right for thinking about prescription drugs. But that's not really a quibble so much for them. That's kind of a more general thing for how we use these sort of models. All right, and I'll stop there.
So you have about 2 minutes if you want to respond to anything Justin said, or one of your co-authors wants to bring up one of the major discussions in the chat. And while you're thinking about that, I'll just remind everybody to hold on to these comments because we'll be sending people to author rooms after the next presentation. So.
Okay, thank you, Justin, for those comments. I'm very grateful that you used the home run emoji or home run clip art on that first slide. We've have high hopes for this paper, and we really like working on it. I just glanced at the chat now, and I'm kind of overwhelmed at all, how much has been going on while I've just been focused on trying to keep an eye on the slides. So I don't know if my co-authors want to chime in or how to do this. Let me just say in terms of health effects, that's something we're not touching on in the paper so far. That's something we hope to study eventually, and we think that's definitely an area that's fruitful for future research. Like something we're interested in is you've got identical people leaving the hospital, and some of them have a history of being liquidity sensitive and others don't. And they all are, you leave the hospital after a major event with all sorts of prescriptions that you have to fill. Sometimes you have some pills that the doctors give you in the hospital, but you've got all these instructions and you go out into the real world and you face all these co-payments for a part of the population that might actually be devastating in terms of health. And that's something we do want to look at eventually. Where is the missing mass? That's something we're struggling with and thinking about. It's very difficult to think through because we know, because you've got pills that people are using up as they go, and then some days they forget to take their pills, and so it's hard to understand exactly what the trend should look like.
Can I comment on that too?
Please, yeah.
Thanks for that, Justin. Yeah, this is something we've been thinking a lot about, and one of the things that we had come up with was exactly what you suggested, of kind of differencing out using the no copay group. And it turned out that the no copay group, the day of the week patterns were such that they didn't completely difference them out. And so you still, which was, tragic. But I like your idea of doing it with the first fills only, because which we hadn't tried, because I think that one of the reasons why they didn't difference out was probably the refill patterns. And if we try it with the first fills, that could work. One thing that came up in the chat related to this from Dan is something that he suggested, which is the way we've been thinking about it too, is that we think that the results of the bigger price elasticities for the sensitive people at least suggest that the spike isn't all retiming, right? But that there's actually some foregoing going on, and that's one way to interpret those results, is that because they respond much more, that does suggest that part of what's going on is a kind of foregoing because I'm sensitive thing. But this has been like our biggest struggle, is trying to find the missing mass, and I like the first fills idea. We'll see what we can do with that. Thanks.